Hello everyone, how are you all? All right, so let's start our cardiology session tonight. So by this time, you know that this is our last session for the first 2 weeks free sessions. Now, obviously, you guys has gone through a lot of classes with us for the last 2 weeks. Not just 2 weeks, we started also one another class was on psychiatry. So I guess that you guys liked our approach and also that the cages, the clusters, that how we are running the course. Now, tonight we are going to do a theory-based role play session. So by this time, some of you might already got some idea that how the course are designed. The course is designed in a way so that you get the most benefit out of the discussions. As you can see that first we did the MSc theory session for psychiatry. And then just after that, we did a psychiatry MSc role play. It doesn't mean that psychiatry is done. There is a lot of cases we will do in our course in terms of psychiatry. It's just a part of psychiatry, which is very important for the exam that we finished. And then we did the cardiology. Cardiology usually takes 2 classes. So we had a cardiology 1 and 2 session. And then tonight we are going to do that cardiology-based role play session. That means everything that you have learned for the last 2 theory sessions, we are going to do role play on that. And that's how you learn, and that's how you actually find out how your theory knowledge can be helpful for some of the questions which are very high yielding for the exam. And in the middle, also we did one random role play session, right? So now that random role play session has nothing to do with the theory session. It's just based on recent sample questions, which are very, very important for the exam. Throughout the course, it will be designed in this way. So in 1 week, you will get theory sessions, you will get a random role play session, and in some weeks, you will get theory-based role play session also, just like this week. All right. Now, remember, we did not finish one particular case from your cardiology theory session, the CVS risk assessment. We are going to do that first, and then we are going to do the role play. Just give me a minute. Let me open that file. All right. So CVS risk assessment. This is a very important case for the exam also. So you are a GP, a middle-aged man comes to you to have a consultation after his brother went for coronary bypass surgery 2 weeks ago. He is obese, no other past medical history. The task will be to take a focused history from the patient, physical examination finding from examiner, and explain what will be the initial management. Now, this is one kind of CVS risk assessment question. There is another question in which they give you the CVS risk assessment chart, and then they ask you to explain it. All right, now this one will not, you will not get the CVS risk assessment chart for this particular case, but you have to ask it from the examiner that if you're in the face-to-face, you have to at least say that you would like to check the CVS risk assessment chart. Okay, so how we are going to start this case? Obviously, remember one thing that you got to know from this note that his brother had a bypass surgery 2 weeks ago. So initially, when you start your case, you should be a little bit empathy for his brother. At least ask that how he is doing. So you can say, hi David, this is Dr. Arshan, one of the doctor here. I got to know from the notes that your brother had a bypass surgery just 2 weeks ago. I'm really sorry to hear that. How's your brother doing now? See that this is how patient feels like, well, this doctor feels for me, or this doctor care for me. And that's really important. Once you do that, then you can say that, thank you so much for coming here today, David. I really appreciate that you are here to discuss about it. Now, to find out your risk of having a heart attack in the future, we need to ask you a few questions. And also we will do some physical examinations, and then we will discuss about your risk and further management. Is that all right with you? Yes, doctor. Okay, so now when you come to your risk assessment question, it starts with a mnemonic called ABCDEFS. So what is ABCDEFS? A for alcohol, B for blood pressure and body build, or you can say BMI, body weight. C for cholesterol, D for diabetes and diet, E for exercise, F for family history of diabetes, high blood pressure, or any other heart condition, S for smoking and stress. So this is very important to ask to find out the risk factor this patient having. Now, you are not going to start your question with alcohol and blood pressure. So normally you can just start with asking that, how are you feeling at the moment? Currently, do you have any chest pain, any shortness of breath, any trouble with your vision, okay, any difficulty breathing, any racing of your heart, any pain in your leg? So just some serious related complicated questions, or you can say serious related symptoms you will ask first. So find out if this patient is having any symptom currently or not. Once you have done that, then you can start asking one by one that, do you drink alcohol? Do you have any history of diabetes or blood pressure? How about any history of any increased cholesterol? I would like to know your typical daily diet. Do you do any exercise? Any family history of diabetes, high blood pressure, or heart condition? Do you smoke? Any stress at your work? Any stress at your home? Any financial issues? Any other past medical or surgical history? So you just use this mnemonic to ask all the questions that you need to ask. Okay, and lastly, just finish with the, just say that thank you so much for all the information. So history will not be very, very long in here. It's just asking all the ABCDEFS questions. Once you have done that, then the next task is PAP, that means physical examination from examiner. Now let's assume that this is a face-to-face exam. In that case, you have to find out in the general appearance if there is any sign of high cholesterol, like genital asthma or xanthoma, or any corneal arcus. Find out about the pickled, so pallor, icterus, clubbing, dehydration, or edema. Ask about vitals. Very important to find out vitals, especially high blood pressure. Also, BMI is important. This too is important for your risk assessment. And then just do the CVS respiratory and abdominal exam. You already know how to do the CVS examination. And now we will discuss the respiratory and abdomen when we will go for this cluster. Lastly, ask about office test, especially urine dipstick, blood sugar, and ECG. Now, it's a very important thing that at least mention that you would like to have a look on the cardiovascular risk assessment chart. Now, most of the time, they will not provide you this risk assessment chart in this case. So whatever it is, you have already got some risk factor from the patient. So explain that. So say that from the history and physical exam, I have found some of the risk factor, like you have high blood pressure, your body weight is higher than normal, you have diabetes, and your diet contains fatty food rather than healthy balanced food. And also you have been smoking for 20 years. All this can put you on some risk of having heart-related complication in future. I haven't got the 5-yearly risk assessment chart with me now, but when I get it, I will put all your risk factor on those chart to get a definitive risk factor for you in the next 5 years. You can always say something like that. Please don't worry. We can't we still have a lot of time to act on this. And by adopting a very healthy lifestyle, we can prevent this complication in the near future. So the first thing that I would advise you to cut down your alcohol to safe level. Please try to maintain an ideal body weight. Please try to stop smoking. Take a healthy, balanced diet. And please try to do some exercise, at least 30 minutes brisk walking most of the days of the week. And if you are under a lot of stress, please try to take some rest, make a relaxed life, try some holidays or do some relaxation techniques. It's very important to have a very good balance with your work and personal life. Okay, so say something like that. It usually means a lot for a patient. Also, I would like to arrange some investigations to find out your risk factor definitively. Like I would do a full blood exam, your kidney function and liver function. I might do an electrocardiogram to get a baseline ECG, your blood sugar level, and a lipid profile. And then lastly, give some 4R. Okay, so these investigations is a part of your CVS risk assessment chart, right? Remember in MCQ, when you need to put on the information on the risk assessment chart, you need the lipid profile. That means your HDL ratio. Okay, so it's very important that you need to do this blood test. And this is the risk assessment chart, as you can see. So if I haven't seen this coming, but you should know how to get the result from this, because what they will do, they will give a scenario like this, and they will give you a blood pressure. You need to know the systolic blood pressure mainly. You need to know the cholesterol HDL ratio, which is 8. You need to know if, sorry, you need to know the age of the patient and sex of the patient. And also you need to know if he is a smoker or not, and if he is a diabetic or not. So those are the important information to have an estimation of the cardiovascular risk. If you look at here, you know that this is excuse me, guys. Sorry. So you can see in here, it's a people without diabetes, and you can see men and women, smoker and non-smoker. So that's why we need to know those things. And also you can see the age in this line. So if you see it's a 57-year-old man and he's a smoker. So 57 is good here. It's an old man and is a smoker. So we are looking mainly on this side, right? Now, always remember, when you are doing a CVD risk assessment, you need to look for this systolic blood pressure on the y-axis and the total cholesterol HDL ratio in the x-axis. You can see in here that systolic blood pressure is 160. So one of the other things that's very important not to forget is that you can see 120, 140, 60, 79. The important thing to understand that what is the maximum systolic blood pressure you can put in this box. It's not 120, you can put 130. So up to 130 is the maximum systolic blood pressure will be in this box. But if it's 130, that becomes marginal. You should go to this next box always. Any marginal, you go to the next box. Same in here, it's 150. This is 170, so just like that. Now, if this patient's systolic blood pressure is 160, where we are looking for? This patient's age is here. So we are mainly looking into this particular box, right? Now, 160 will be in here. So obviously this line we are talking about, right? Now we need to know the cholesterol HDL ratio. Cholesterol is 8 for this patient. Again, what is the highest cholesterol that you can put in this box? Is it 4 or no? 4.5. 4.5 is the highest box, highest cholesterol level you can put here. Same in here, 5.5, 6.5, 7.5, 8.5. Now this patient is 8, obviously, so we are looking for this box, right? So if we go up, so this red box is the patient's box. Now, if you compare this red box in here, you can see that red box has the highest risk of having a 5-yearly cardiovascular risk. So more than 30%. Okay, so this patient is in a high risk category to have a 5-yearly risk of having a heart-related complication in the future. So that's how you read it from this chart. Any question, guys? And the explanation, management, everything will be same like before. Now, yes, he might need medication. If it depends on what is the risk factor he has got. If he is hypertensive, then yes, he will need medication. Like his systolic blood pressure is 160. Someone who is high risk and having high blood pressure like this, yes, this patient will be a candidate for a medication also. So you have to start with antihypertensive. Patient's cholesterol is also high, so he has to be started with a statin as well. Did not get you, Dr. Edmund. So what if the blood pressure is less than 120? What's the purpose of the question, Dr. Edmund? So do you want to know the management or the risk chart? Normally, we would keep the blood pressure below 140 by 80 or below 140 by 90. That will be the highest we can go for. Okay. We can do that. That patients will fall under the first box in that case. Normally in the exam, you will not get something like that. All right, guys. So that finished our cardiology theory. We want to start with role play today. Who wants to do role play? Okay, I think I have already got enough people to do role play. Now remember one thing, I told all of you in the first class that we always follow a rotation in the role play so that everyone gets it. Now, whoever has done it with Dr. Cynthia, whoever has already done with me in the first MSc role play, today you guys are not doing it. Okay, so someone who is new, they will do it today. I think like I told someone of you who will be doing role play today at first. Who was that? I think, yeah, Dr. Jody was there, right? So she's not here maybe today.
I have done with Dr. Cynthia the other day.
Okay, good. All right, that's great. So let's just do in a way. Now, always I will keep a diary with me that who is doing the role play so that we can have some idea at the end of a month that who is doing role play and who is not doing role play. It's important for all of you to come And so that the important thing in here to do a role play is break your, like, like everyone has a thinking in their mind that, well, there is a lot of people in front of me. What if I do some stupid thing? They will laugh at me. So to break this thinking, all of you needs to come and do role play. Once you are past that, once you can think, well, whoever is laughing behind me, that's fine. I don't care, because they don't know you, right? Most of you don't know each other. And even if you do something stupid, that's totally fine, because you are here to learn something. And all of us did something stupid when we did role play at the first time. Someone doing it really nice, it means that she is practicing and she might be already with these role play things. So you don't need to compare yourself with someone who already knows everything and still doing the course. So there will always be difference from person to person depending on the level. Someone will be beginner, someone will be like in the middle of their preparation, someone will be totally fit for going for the exam, right? So there will be people like that. But what you need to think in your mind is that, well, whatever it is, I'm going to try myself. I'm going to see that what I'm doing in front of all of these people. If you can do role play in front of 50 people, it's nothing to do a role play in front of 2 people in the exam. Okay, so that's the spirit. Now let's start with Dr. Nusrat. Did you do any role play so far? If not, then you can just unmute yourself. We will start with you. And then Dr. Moni.
Doctor, hello. I did last day.
Okay, so let's start with Dr. Mani then.
Okay, thank you.
Dr. Mani, unmute yourself, please. I can't hear you, Dr. Mani. Your audio is not working. Can you say something now? I can see that your mic is running up and down. So it's a problem. I can't hear you, Dr. Mani. Okay, what I will do, Dr. Mani, so we'll try it again next time. See that what's your problem with the role play, okay, or with your audio. But let's go to the next person. So, Dr. Raksha, did you do role play so far or not?
Yes, I did.
Okay,
I did
and
last
then
session.
okay, all right. Now let's try with Dr. Salma. I think Dr. Salma, did you also do?
No, I didn't do it yet.
Okay, all right. Let's do the role play then. Let me give you the case. Just a second.
Yeah, sure.
Okay, so this is your case, and we're going to give you 1 minute in the outside to have the reading, and then 7 minutes 30 seconds inside. Okay.
Okay.
And this will be an online kind of exam. Okay.
Okay, doctor.
All right, so this is your patient. Your patient name is John. You can start.
Hi, I'm Salma, one of the doctors here. How are you now, John?
Yeah, doctors, I'm just scared about this chest pain. I just don't know like
Okay.
what's I'm having. I think I'm having a heart attack, doctor.
Okay, let me quickly take a look at your vitals first, then I will get back to you. And so, John, can you please rate your pain for me in 1 to 10 scale, when 10 is the maximum?
6/10.
Okay, and did you take any medication to subside the pain?
No, doctor.
Okay,
No.
would you like me to give you some medication?
Yeah, that would be nice.
Are you allergic to any pain medication?
No.
Okay, I will give you some pain medication, but it will take some time. And in the meantime, I would like to ask you a few questions so that I can get an understanding like what is, might be the reason behind your pain. Are you happy with that?
Yeah.
Okay, so can you please tell me exactly where the pain is?
It's in the left side of my chest.
Okay, and do you think the pain is getting worse with time?
No.
Does the pain traveling anywhere else?
It's going to my left shoulder.
Okay, and can you describe the type of pain for me?
I don't know, like it's just someone is putting knife through me.
I'm so sorry to hear that. And does it started all of a sudden?
Yeah.
Okay, and can you please tell me, is there anything that makes it a little bit better?
Sometimes like if I just sit forward, then
Okay, anything making it worse?
I'm not sure, doctor, but I can't lie down.
Okay, and is this the first time you're experiencing such pain?
Yeah.
Okay, and can you please tell me, with this pain, are you not having any shortness of breath?
No, doctor.
Okay, and can you please tell me, in the recent time, do you notice that you are having some funny racing of your heart?
No.
Okay, any recent flu-like illness you experienced?
I had a bad flu 10 days ago.
Okay, did you take any medication for that?
No.
Okay, and the recent time, do you notice that you are feeling sudden dizzy?
No.
Any recent fever or cough?
No.
By any chance, before you start having your pain, you hurt your chest?
No.
Okay, and in the did you travel anywhere recently?
No, doctor.
Okay, do you notice that you are having some water brush in your mouth?
No.
And do you have any rash over your skin?
No.
Okay, are you generally an anxious person, John?
No, doctor.
Okay, and can you please tell me, do you smoke?
Yeah.
Okay, may I know how many sticks per day and for how long?
It's been like since I am teenage, but mostly 15 cigarettes a day.
Okay, if you give me permission, I would like to arrange another consultation to discuss about the smoking. If you give me permission, then I will do that. And what about alcohol,
Sure.
John?
Just occasional.
Okay, by any chance any recreational drugs?
No.
Are you using any medication prescribed or over the counter?
No.
Okay, is there any past medical or surgical history that I should be aware of?
Not much.
Okay, and is there any family history of any heart disease or any lung condition that I should know?
My mother has hypertension.
Okay, and do you have any kind of any similar kind of disease, high blood pressure or high blood sugar?
I haven't checked.
Okay, no worries. I will look for you. So thank you so much, John, for the detailed history. I have an ECG in my hand. Let me go through it, then I will get back to you. Are you happy with that, John?
Yes, doctor.
Okay, thank you, examiner. First of all, I can see it is a 12-lead ECG and I can appreciate the rate is regular. And I can see there is a presence of P wave followed by QRS complex. I cannot appreciate any problem in QRS complex. They are not abnormal shape. In ST segment elevation, I can ST segment, I can see that yeah. I can see concave ST depression mostly in most leads. Yeah, thank you so much, examiner. I cannot appreciate any of the problem. So can I see my task again, please? Yes. So thank you so much, John, for the detailed history you gave me. And after talking with you and checking the ECG, I think most likely you are having a condition. We called it pericarditis. Have you ever heard about it, John?
No, doctor. What's that?
Okay, sorry for my medical jargon. Let me explain it to you. So what happened, John? We have our in our body, deep inside our body, as we have heart has some coverings overlying it. And in your case, what I found that you have some infection going on over there. And that might be the reason why you are having this pain. And there would be few reasons why you are having this infection over your heart covering. So in your case, I'm thinking that it might be due to the previous flu-like infection you are having. Because of that flu-like infection, you might be having those symptoms right now. Are you with me so far?
Yeah.
Yes. For
What
you,
if,
John?
I think like, do you think like it can be due to the Pfizer vaccine that I have given just 2 weeks ago? Because previously I was just a healthy person and now I'm having this kind of pain.
I can really understand your concern, but let me reassure you that is very unlikely in case of vaccine. In case of vaccine, those kind of complications are very unlikely, and we actually have a lot of studies in our hand, and nothing suggests that it could be due to Pfizer vaccine. So let me reassure you that it is because it is not because of your vaccine. Okay, John?
Okay.
Okay, I was also thinking about it could be some other problem, such as it could be due to maybe you are having a heart attack, which you were worried about. But again, I didn't find any symptoms like that, such as you don't have any sweating or you don't have any shortness of breath, funny racing of your heart. I was also thinking about it could be pneumonia. Again, you don't have any fever or cough. I was thinking about it could be due to pneumothorax. Thank you.
Thank you. Thank you, Dr. Salma. So you did really good. I think like you did not miss anything in the history. Your approach was good. But I think like a couple of things I would add in here. This is like a very, very important kind of case and to pass, right?
Yeah.
Now,
yeah.
in this case, a couple of things that you need to make sure that first, I think like when you started the case, you just said in this way, "Hi, John, how are you?" So it's a good idea to say that, like introduce yourself with the patient also. So say that, "Hi, John, this is Salma, one of the doctor here in the emergency department." Okay, so in that way, if you start, then what will happen? You will have your own grab on this patient. And you can say that I got to know from the notes that you are having this chest pain, which has started 6 hours ago. Now, what will happen if you start in this way? You can give some reassurance to the patient. You can also, like, you will have some grab. Otherwise, what will happen when you say, how are you? Patient will give you all the answers to that open-ended question. So in case you might not get that time to reassure or introduce yourself even. So that's one thing I would like to change.
Okay, sure.
The good thing that you said that, well, I would like to check your vitals. I know that this is kind of like we don't have anything else to do because we can't get the vitals, but it's always a good idea to check the vitals like this as well. Like at least
actually it sounds very weird to say
it is,
but yeah.
It sounds so weird. I know, like, because like we are just saying it and then this next time we are just asking questions. But what in that, like, at least examiner gets to know that, well, you want to check it, because this same examiner is also taking exam in the face-to-face where he knows that people are asking the same question to him. So that's one thing. Like, I always say that it's a good idea to do it, although it's a little bit of weird. Now, the exam is a little weird also. Like, you are explaining physical exam to the patients. So that's weird. Never ever we will do in the real life. So it's just for the purpose of exam. I think we can do that. Again, like, if anyone doesn't do it, it doesn't bother. It doesn't matter also. I haven't heard that for this particular thing, people are failing. Then another thing that it's a good thing you have done, that you haven't thought that it's a heart attack. Like, if 35-year-old having a heart attack, not very common. Okay, so it's not, you need to start with the aspirin, all of those things that we do if this patient was a 50-year-old, we would do that. We would arrange a ECG immediately. We would do all those stuffs initially. But for a 35-year-old, no, it's not very important. And also the timing, you can see 6 hours. Most of the time, if you say ST elevated AMI in the exam, usually patient comes with 1 or 2 hours.
Yeah.
So always you will get some idea from the stem that what question it is. Because in exam, you either get pericarditis or you get a ST elevated AMI in terms of chest pain case. But always keep an open eye. It could be just a costochondritis also sometimes. Anything can be. So that's the initial thing that I think that would be a good idea to do. Your history about the chest pain, nothing to add, everything you have asked in terms of history. Interpretation of ECG, I think like a couple of things that you have missed. One is you did not
I rushed through.
Yeah. Rate if you said rate is elevated or rate is high, that's fine. Regular, you can say that. And PQRS is okay. Now, one of the important thing that you said, I know that you did it just by the pressure of the exam. You say that there is widespread concave shaped ST depression. It's not a depression.
It's elevation.
All of these leads are ST elevation. See that's something happened quite commonly in exam also. Like, you will think you know the things, but still you will just say something wrong. Now, if you say ST depression in this case, you will not get marked in the ECG part, because that's the most important finding in this ECG.
Yeah.
Right. So what can happen if you get 1 or 2 in this task, then ultimately, even if you're doing a very good history diagnosis differential, ultimately you can even fail this case.
Yeah.
Right. So that's something which is very important. Some of the stuffs are very, very important for the exam. Like, if you don't ask some of the history, which is not important, they will not bother. But if you say ST depression in here, yes, they might bother about it. And diagnosis pericarditis, and another thing, like, see the twist at the end. I asked you that, doctor, I had a Pfizer vaccine 2 weeks ago. Can it be it? It's so common at the moment in GP practice, in hospital. Patients come with chest pain and ask, their first question is, I had a vaccine 2 weeks or 1 week ago. Then everything that I'm having, everything started after the vaccine. it's like out of 100 patients, 80 patients says something like that. So what you have to do in that case, and it's just matter of time in the exam, you will also get some kind of patient like that. Okay. So in that case, now you never ever say that, no, it's not the case. If patient thinks like this is due to my COVID vaccine, you always appreciate them. Say that, John, I do understand your concern, and I really appreciate that you asked me this question. Now, do you guys know that, yes, Pfizer, Astra, all the vaccines that we are giving in Australia, every one of them can cause myocarditis, pericarditis as a complication, right? It's not like it's not a possibility, it can cause it. So there were cases in where we have diagnosed it's a vaccine-induced pericarditis, and that's actually a name of it. So there is a possibility also. Now you can't say that, no, this is not the case. Now there is no way we can be sure about it, because he had a viral flu that can be the cause, or if he had a COVID shot like 2 weeks ago, that can be the cause of pericarditis also. So you have to say, yes, there is a possibility that it could be related to your vaccine as well. But because you had a flu-like illness just about a week ago, I'm thinking that it could be related to that as well. Now, the most important thing is that it's not about the cause that I'm worried about. Now, right now, we know that you are having pericarditis, and the best thing about it is that it's not a serious condition. And what I would like to do, that I would like to give you some painkiller, and you just need to take some rest, and everything will be fine. There is nothing you need to worry about. And most importantly, it is not a heart attack. Okay. If investigation comes in this exam, you need to also arrange an echocardiogram along with all the blood tests. Okay, to be sure about pericardial effusion, because it's a very common complication of pericarditis. Okay, so just don't say that it's not the possibility. Say that it's less likely, but it can be a cause as well.
Okay.
Okay, all right. So you did good, Dr. Sama. Very happy with your approach and everything. Just be confident. Don't say ST depression when you are seeing it's ST elevation.
It's my common problem. I know it. I have this performance anxiety. Yeah.
Oh, that's fine. You will get over it, I know.
Hope so. Thank you, doctor.
All right, guys. So I hope you learned something from this case. See that the cases are so easy. You know everything, but still things can go south, like in many ways. We don't even know that. All good. Now let's start with another. Who was next? So I think I can't find anything from Dr. Manir. Then Dr. Raksha, did you do role play with me? Yes. Dr. Salma, you did. Dr. Jody, you did. Dr. Asma Wasim, I think you did not, right?
Yes, I didn't do yet.
Yeah. Okay, so let's do it.
Yes, sure.
I can't hear you properly. Can you say something so that I understand that it will not be hard to understand you?
Can you hear me?
I can, but it's kind of like maybe the microphone is causing. Are you using a microphone?
Just a second. I was using a
Yeah. Try to disconnect the microphones and just use your laptop. Maybe that will make your sound more clear. Now?
Can you hear me now?
Yeah, so it's a lot better. Okay. Now that's another thing, guys. Like when you are appearing for the exam, especially like let's say in the online exam, you need to make sure that you sound clear. It's not their job to make your sound clear or your video clear. So if you are going for an online exam, always do these things. Like try to do a face-to-face video with your partner and see that how you are looking, How is your background looking? How is your sound? How is your video? Everything. You should check it first rather than getting it in the exam. Because in exam, like they will say like it will not affect your marking. But as a human being, if you don't sound okay, if your background is not all right, and also let's say your video is blurry, it affects your performance in a way. So you have to consider those things as well. All right, Dr. Asma, I will give you the case. Just give me a minute, guys.
Yes, sure.
Okay, so this is your case. You have 1 minute to start the case.
Is this a hospital setting or a GP practice?
Sorry, yes, it's a hospital practice.
Good. Should I start now?
All right, just let's see here. Okay, so your patient name is Jenny. You can start.
Hi, Jenny. My name is Dr. Asma. I'm one of the doctors working in the ED today. I'll be looking after you. How are you doing?
I'm okay, doctor. I'm just worried about these frequent falls that I am having.
Yeah, I saw from your notes you have had a few falls recently. I would like to ask you a few things about your falls. Did you have a fall before you came here?
No, the last fall I had was about 2 days ago.
Mm-hmm. And when you had the fall, what were you exactly doing?
Just every time I'm trying to get up in the morning, I just feel so lazy, and sometimes I just have a fall.
Okay. Okay. So before you have the fall, do you experience any or feeling, any unusual feeling like dizziness or any blackout?
I feel dizzy, that's all.
Mm-hmm. So that I So we're talking about your falls. So like how many falls have you had? Total number of falls have you had up till now?
I can only remember the 3 falls in the last 6 months.
Okay. I would like to ask you about all the 3 episodes of the falls. So were they similar episodes or like were they different from each other?
It's always the same, doctor. It's like in the early morning when I'm just trying to get up, I have a fall.
Okay. So before have okay, so you have had 3 falls, and do you pass out when you have a fall, or what happens when
No,
you have
I
a fall?
don't. I
You
I
don't pass out.
don't lose consciousness. I just feel like I'm going to have a fall, and sometimes I also fall in the ground.
Okay. Did you hurt yourself when you fall down?
Not yet.
Okay. Have you had any head injury in the past?
No, doctor.
Okay. Do you experience anything unusual before having a fall, like racing of heart or sweating or any pain in the
No,
chest or any pain in the head?
no. I feel blurry.
You feel blurry. Okay. Um, do you experience any pain in your joints?
Yes, doctor. I have like knee joint arthritis. It's for a long time. It's just killing me.
I can see from your notes that you have a few medical conditions, and I can also see that you're taking medications for them. Has there been any change in your recent medication?
I'm not totally sure, but my other GP, he started one new medication for blood pressure. That's all.
Have you had any issues in your vision recently?
With the vision, no, doctor.
Any weakness of body?
No,
Okay. Any disturbance in your walking pattern?
no, but it's just like my knee hurts when I try to walk or go upstairs.
Have you had any vomiting or diarrhea recently?
No, doctor.
Tell me about your diabetes. Is it well controlled?
Yes.
Okay. Have you, when you had the falls, was it before you had any meal?
I'm not sure, doctor, because usually I get up in the morning and then it happens.
When did you last visit your specialist for your diabetes?
I think 6 months ago.
Okay. And what about your blood pressure? Is it well maintained or well controlled?
I'm not sure, but recently I got high blood pressure and my doctor started with this medication.
New medication. Okay. Um, uh, does anybody in your family had a sudden death?
No, doctor, as far I don't know.
Okay. After the fall, what do you feel?
What do you mean? I just feel crooked and I don't, I'm
Mhm.
just worried
Do you have
to
anybody
break
to
my
take
hip.
care of you at home?
No, doctor, I live alone.
You live alone. Do you have any family or friends who come to visit you?
I have some good neighbors. They come and visit me.
Mm-hmm. Okay. What have you been taking any other medications apart from your normal medications? Any recreational drugs?
No, doctor.
Do you smoke?
No.
Do you drink alcohol?
Yeah.
Are you allergic to any medication?
No, doctor.
Okay. I would like to do an examination, and I would like to request my examiner for the examination card. Okay. I would like to talk to my patient now. Jenny, from the history and from the examination, I have come to the conclusion that there might be a few reasons for your falls. But to reach a definite diagnosis, we might need to do some blood test and some scans. But first, I'm going to explain to you with what could be the reason for your fall. So, as you have a few medical conditions like diabetes and hypertension. So, first of all, the medication given to control blood pressure, they can also cause dizziness and fall. And regarding your diabetes, because you have not visited your specialist within last 6 months, I think your diabetic medications also need readjustment. And diabetes in itself can cause the falls because it can affect your vision. It can affect your joints and the sensory portion of your joints. And also, you're taking a lot of medications right now. So that could also be one of the reasons for your falls, because people who are taking a lot of medication, so those medications kind of interact and they can also be a cause for the fall. You're also having joint pain, knee pain. So that can also be one of the cause for the fall. But like you're saying that when you wake up in the morning, mostly at that time you have the fall. So that could be due to one condition called postural hypotension, in which your blood pressure fluctuates when you change your position, and that results in loss of balance and causing a fall. Are you with me so far, Jenny?
Yes, doctor. Thank you. All right. So okay, I'll just mute for the moment, Dr. Asma. But you did really good. I'm really happy with your approach and everything. You sound so confident. I was so happy to answer your all questions. That's really good. Okay. Now, the couple of things that I would like to add in this case. So the first thing to remember in any of these cases is that if they give you a task like this, like give differentials with reason, now there is no task of giving an appropriate diagnosis, but it's still always start with your best possible diagnosis in these cases. That means what is the most likely diagnosis for her having a fall, guys?
Postural hypotension.
Right. So if it's so evident, according to the history, that when she's getting up in the morning, she's feeling dizzy and then having a fall, no loss of consciousness. So it's not a syncope case, but it's a recurrent fall case. And we can see from the blood pressure perspective that systolic blood pressure on sitting 145 and on standing 115. So there is more than 20 gap in here. So that means it's a postural drop. What else we could add in this case that can cause the similar kind of fall she's having? Now, when you say that
polypharmacy.
Sorry? Yes, so very good, doctor. So now postural hypotension is the diagnosis. Now, what are the causes of postural hypotension? Most likely in your case, it's the polypharmacy that you are having or the multiple medication that you are using. And most importantly, one of the new medication for your high blood pressure has been added recently. And that medication can reduce your blood volume so that it can reduce your blood pressure. Okay, while it is reducing your blood volume, you can also feel a kind of dizzy and you can have a fall just like that. Okay, so that could be the one of the cause. It could be due to like any sudden increase of any of the medication that you are using. The other medication that you are using, like amitriptyline, that also can cause postural hypotension or having a fall. So what I would like to do in this case is to make a full medication review with your other doctor who has started you with this medication. And then if needed, we will try to reduce the dose or change it accordingly. So that's the polypharmacy induced. What else can be? So you can also give that it's not only just the polypharmacy which causes postural hypotension. It can be due to like any recent infection, any diarrhea, any vomiting, but you did not have anything like that. Okay, now what else? This patient having pulse rate 45. If you don't use
Bradycardia.
this term, yeah, so she's having bradycardia and ECG also showing sinus bradycardia. Someone who is having bradycardia, that also can cause fall, okay, because they're dizzy. So that dizziness sometimes lead to fall in this like older population. So that's a very good thing. Now, there are cases in which you don't get anything apart from just a sinus bradycardia, and that's your cause of fall. So very, very important thing is to remember this thing, that sometimes even just having a like a severe bradycardia, patient can have dizziness or a presyncopal attack. Now, these are the most important thing in here. Apart from that, also, I think like Dr. Asma has included that. That was really nice, that diabetes can cause it. Now, this patient's diabetes is well controlled, like having a 8 BSL as a RBS, like a random one, it's all right. But diabetes itself can cause complications. So it can be diabetic neuropathy. It can be like diabetic retinopathy. It can be diabetic autoneuropathy also. One of the good thing in here is to ask question in the history about diabetic autoneuropathy. People with diabetic autoneuropathy gets heartburn and very, very early satiety. They also get kind of dyspepsia or indigestion. Okay, they sometimes have difficulty with their bowel motion, urinary problem. They also get sexual difficulties. So we can ask these questions in one go. Like, do you have any trouble with your digestion? Do you get any symptoms of frequent burping, reflux, heartburn, anything like that? Any trouble with your bowel motion? Any trouble with your pee? Okay, any trouble with your sexual function? So we can ask those questions in here and say that it could be diabetic autoneuropathy also. Next is bilateral knee pain. And I already said that it's arthritis. So yes, arthritis itself can cause fall. So these are the most important causes in this patient. Apart from that, we would have to give all other differential diagnoses of having a recurrent fall. Okay, so Dr. Asma has asked pre-syncope, post-syncope question, but not any syncope question. Why? Because this patient did not have any syncope, so we don't need to ask those questions. And that was really smart. So you need to find out that which questions you don't need to ask. Like obviously you don't need to ask this patient like, how long were you unconscious? This patient did not have any loss of consciousness. So we will not ask those questions, right? So that's important. Okay, so in this case, the history will be pre-syncope, syncope, little bit like just question about loss of consciousness, and then post-syncope question, followed by all the other CNS, CVS, all other differential diagnosis of syncope will be here. But very important is to find out the medication related question, like who takes care of your medication, any recent medication has been added, have you increased any of the dose recently? All these questions will come into play, and going in detail about the diabetes also. We don't need to go in detail about knee pain, Dr. Jahidul. Just knowing that it's a chronic arthritis, it's all that we need to know. All right, so I think like you did good, Dr. Asma, but I think like you were very good with the history, but when you kind of came into the explanation, then if you would start with the, now let's say if you would start with the, like saying that most likely the cause of your feeling dizzy and having a fall, especially when you are getting up in the morning, I'm thinking it's most likely due to a condition known as postural hypotension. Okay, then say what is the most likely reason of postural hypotension, describe what it is, and then talk about sinus bradycardia, then go in for diabetes and the chronic knee pain, and then go for all other differential. That would be the best approach in here.
Yes,
And
thank
yes, that's important, asking about the home situation like loose carpet, poor lighting, okay? All those questions should be asked as well in here. Another thing that I think you missed is going in detail about the alcohol. If you would ask me that, I say that, yes, doctor, I drink alcohol. You did not ask that how much you are drinking. I would give you a very high amount of alcohol drinking in here. So I would say, doctor, 8 drinks in a day or 10 drinks in a day. Someone who lives alone and having drinking level like this, that's alone can cause all the fall.
Yes.
Okay, so very important to think in this way as well. Like these sort of cases in the exam, there will be multiple causes of having a fall. Okay, and you need to address each and everything that can be the possibility in her. All right, so thank you guys. Next. And unfortunately, Dr. Manir, still I can't hear you. So we'll just need to find out why I can't hear you later on. Yes. No, not the alcoholic neuropathy. Can be alcoholic neuropathy if patient saying I have lost sensation in my lower legs or my foot. Then we can say alcoholic neuropathy. Sometimes alcohol intoxication or drinking a lot of alcohol, patient feels dizzy most of the time. And in the morning, they get a hangover and they have a fall. So this can happen. So it could be alcohol intoxication. Sometimes patient might try to reduce their alcohol intake and then having alcohol withdrawal symptom, and then eventually alcoholic neuropathies and all other symptoms comes into play later on. Okay, so, all right, I think like what I would like to do, we'll start with the next case later on. Now let's take a 5-minute break. Okay, after the 5-minute break, who is going to do the role play? There was some list initially. I would just have to look into that. I'm done with Dr. Asma, then Dr. Asmaul Husna. You did not do any role play, right? So far? Dr. Asma is not here, I think. Dr. Jahidul, you did role play last class. Dr. Riham, did you? Yes. What about Dr. Stella? You did not?
Hi, I did not do it yet. Can I try?
Yes. Okay. So what I would do, Dr. Stella, I would take a 5-minute break and then we will do the role play. Okay.
Sure. Thank you.
Thank you. So guys, let's take a 5-minute break and then we will start the role play again. All right, guys, so let's start now. Okay, so Dr. Stella, you're here?
Yes, I'm here, doctor.
Okay, all right, so we'll do the role play now. So let me give you the case. Okay, so this is your case. You will get 2 minutes in here, in the outside, and then 8 minutes inside.
Okay.
So, all right. So this patient name is David. You can start.
Okay. Hi, David. This is Dr. Win, one of the doctors in this GP clinic. I understand from the notes that you have chest pain. Are you comfortable right now, David?
No, doctor. I think like I'm dying, doctor. I'm having severe chest pain. I have never had this before. I just don't know what's happening with me.
All right, David. I'm sorry to hear about that. Can you rate the pain on a scale of 1 to 10, when 10 is the most painful?
It's at least 8, but doctor.
8. All right. So I will organize some painkiller for you. And meanwhile, I will quickly check your vital signs, your blood pressure, pulse rate, respiratory rate, and oxygen saturation to make sure you are vitally stable. Is that all right, David?
Yes, doctor.
All right. So could you tell me more about your chest pain? So where exactly do you get the pain, David?
I've been having it in my left side of the chest, and it started about half an hour ago.
I see. So does the pain travel anywhere, like on your neck or jaw and on your arm?
I can feel it in my left arm.
Left arm. I see. So this is the first time that you have this kind of chest pain?
Yes.
I see. So have you noticed anything that brings it on? Or what were you doing at that time?
I was just walking by the side of the road, and then it started.
I see. So have you tried something to relieve it? Like when you take a rest, does the pain resolve?
No, I've been taking rest. I was brought in by the ambulance, but it's still there.
I see. All right. So apart from the pain, do you experience any other symptoms? Like do you have any nausea and vomiting? Do you have any cold? Hello?
I feel nauseous, doctor.
I see. Do you have any cold hands and feet?
No.
Do you have any sweating?
Yeah, I'm sweating heavily.
I see. So because of this pain, do you feel any fainting, or do you feel any dizziness?
No.
No. All right. I see. So David, do you feel any shortness of breath?
No, doctor.
I see. So do you have any fever recently?
No.
No. Okay. Do you have any cough pain?
No.
Did you travel recently? No.
No.
All right. Do you have any underlying lens problem? Like, have you been diagnosed with asthma?
No, doctor.
All right. I see. Do you have have you noticed any rash on your chest?
No, doctor.
I see. Okay. All right. So apart from this, are you generally healthy?
Yeah, doctor.
Do you have any chronic medical problem like hypertension?
No. No.
Have you been diagnosed with diabetes?
No.
All right. Have you had any surgical operation before?
No.
Okay. So are you taking any medications recently?
No.
Okay. Do you have any drug allergy, David?
No, doctor.
Okay. By the way, David, do you drink alcohol?
No, doctor.
Do you smoke?
Yes, doctor.
Okay. May I know how many cigarettes a day do you smoke?
10, 15 in a day.
I see. So how long have you been smoking?
15 years.
15 years. I see. All right. Apart from this, do you use any recreational drugs?
No.
Okay. All right. So could you tell me more about your BMI? Do you know your BMI?
I don't know, doctor.
I see. I will check after our history station. And then could you tell me more about your typical daily diet? What do you eat usually enjoy?
Everything, doctor.
Do you like to eat fast food and street food?
Yeah, I usually can't cook in my house, so I have to eat from outside.
I see. Do you do any exercise, David?
No, doctor, I can't.
Okay, I see. All right. So do you have any family history of heart disease and heart attack?
My father had a heart attack at 50.
I see. All right. So do you have okay. Thank you so much for your story, David. I will have a talk with my examiner and then I will come back to you. Is that all right?
Yes.
Dear examiner, this is a ECG record of 50-year-old patient with chest pain, and I can see the heart rate is about 60 beats per minute, and it is regular rhythm, and I can see the normal P wave. There's SD changes, like SD elevation in lead 1, AVL, and V6 also in V2 and V3. All right. And there's normal QRS complex. Okay, thank you, examiner. I will go back to my patient now. So David, after the history, and we have checked your electrocardiogram, and what I'm thinking is you are having a condition called myocardial infarct, which is a heart attack. And
I'm having a heart attack, doctor.
Yes, David. I'm sorry to say that.
I'm
but,
going to die, doctor.
No, actually, you are in safe hands right now, and I will organize appropriate management for you. So please don't worry. You can please don't worry. I will organize most appropriate management for you. Okay, David. So we are at the rural clinic at the GP at the rural clinic. So what I can do is I will quickly do. I'll arrange an ambulance for you to transfer you to the tertiary hospital immediately. And meanwhile, I will collect your blood samples, like for the cardiac enzymes, to confirm the diagnosis, and I'll collect appropriate investigations for you. Sorry.
But go on. Go on. It's fine.
Okay, David, I will arrange an ambulance for you and you will be transferred to the tertiary hospital immediately. And at the hospital, you will be assessed by the specialist team with the cardiologist, and the cardiologist will arrange a special investigation called angiogram, which is we will check the blood vessels of the heart. Oh, and then we'll give the vessel dilatation of the vessels in okay,
That's
I'm
fine.
sorry.
No, that's fine. You're doing good. Now have a look into this again. This is the part where you get like, well,
Oh,
I
all
can't
right.
this.
Okay, so at the moment, I will prescribe most appropriate painkiller for you, which is morphine through your veins, and I will give oxygen, and I will give you some nitrate tablets, and you can apply under your tongue.
Yeah. Okay.
Okay. Thank you, doctor.
No, thank you. Thank you very much, Dr. Stella. So it was nice. Like I understand that you were a beginner, but you're trying your best, and yeah, you did good. The history was really nice. ECG was also very good. In the management, because you did not have enough time, then you actually had a mix-up. Now, important thing in exam, as all of you can see, is to read the stem very, very properly, because everything is given in the stem already. And there is everything written in the stem there is a purpose for that. That's important to know, that this is a GP clinic in a rural area, nearest hospital 4 hours away. Now, you can't send a patient to a tertiary hospital who is having ST elevated AMI, and you can't wait for 4 hours, because you could do a lot of other things to save this patient rather than sending the patient to the tertiary hospital. So very important not to bother with that. Now, what we need to talk in here, that's very important. One of the other thing, when you see that ECG given in the next page, you can always ask the invigilator that, like in the initial 2-minute time, that is the ECG available for me to have a look now? Like if you want to see something, sometimes that's given in the next page. Okay, if you just ask it, then they might give it to you. Sometimes they, like, even if you don't ask it, they might give it to you. But if they don't, you can always ask it if it is written like this. Okay. Yeah, even before history, because most of the time in these cases, what happens that they give a ECG already. Like you get to see the ECG in the 2-minute outside time. Okay, so you just need to ask it most of the time that, can I see the next page? Because it's already written in here. And it's not like this, actually, they explain it more clearly in the exam, that like you can always ask the invigilator to show you the next page or something like that. So when you see the ECG in the 2-minute outside, you already know the case. And the task, that's why it is a brief history from the patient. That means you don't need to bother about any other differential diagnosis in here. And that's why there is 3 tasks which you can't finish if you need to take a full chest pain history with all other DDs. So you don't need to bother with that, because you already know that this patient having a myocardial infarction. What do you need to find out? You just ask about the chest pain history, and is it the first time or not? And just some ABCDEFS, the risk factor of having a heart attack. That's all that you ask in here. You don't need to go into the differential diagnosis. What else you have to ask is that this patient cannot go to the hospital. So what is the appropriate management for this patient? You have to go for a fibrinolytic drug, right? So for fibrinolysis, you need to find out if this patient having any contraindication for that. So that comes in your history also. So you need to find out if this patient having any bleeding disorder, is he on any blood thinners or not, having any history of ischemic stroke in the last 3 months, any history of intracranial bleeding anytime. So those contraindications you need to ask in here. Okay. So that's pretty much everything about the history that you ask. Then you explain the ECG to the examiner. Now, one of the other thing I would always do in this particular case, if I get to see the ECG in the 2 minute and I know that this is a ST elevated MI, just after introduction and reassurance, I would like to just talk with the examiner and say those things. You can start in this way. Hi, John, this is Dr. Arshan, one of the doctor here. I got to know from the note that you are having chest pain. And also I had a look on your ECG. Before I start, I would like to know how severe is your pain in a scale of 1 to 10. Okay, then 8 by 10, offer some painkiller, making sure patient doesn't have any allergy to it. That's very important. Once you have done the painkiller, then say that, John, just excuse me for a moment because I need to take you to the treatment room. I will ask my nurse to attach you to a ECG monitor for observations. I would check your blood pressure, pulse rate, respiratory rate, saturation, and temperature. And once I have done that, then I will start asking questions from you. Now, you can start aspirin, morphine, nitrate initially, or because you have already have a task of management, you can keep that time for just talking about this management at that time. That's also fine. As long as you are taking the patient to the resuscitation room or treatment room. Now there is two terms. One is called resuscitation cubicle. That's usually we use in emergency department or hospital setting, and GP setting has treatment room. So because this is a GP setting, you just say that you would like to take this patient to the treatment room and ask for help, call the nurse to attach a ECG monitor with the patient, and then check the vitals. Once you have done that, then you start asking history from the patient, ask all the chest pain related questions, or everything that I talked about. Explain the ECG to the examiner. When you explain ECG to the examiner, Dr. Stella did everything good, but she did not follow the format. Like first rate rhythm that she has done, then P wave, followed by QRS complex, then talk about ST wave, then talk about T wave. I have noticed that none of you has, like, you don't talk about T wave at all. Can you find out any abnormality in here apart from ST elevation? Look at the chest plate. So V1, nothing much. V2 obviously having ST elevation. What is this? Every lead having a T inversion. It's a significant T inversion, right? So you have to talk about that as well. So this patient having ST depression in V1, V2, V3, V4 also, and V5 not too much evident. V6 there is also some ST elevation. Lead 1 there is ST elevation. Lead AVL there is ST elevation, and lead 2, 3 AVF is normal. Okay, so you can't just avoid talking about T inversion. It's very important finding in this case also. After explaining the ECG to the examiner, then further management. Explain the patient properly that you are having a myocardial infarction, which means heart attack. I'm really sorry to say that to you, but John, this is a medical emergency. But I want you to know that you are in the safe hand, and I will do everything possible in my capacity to make sure you get the most appropriate and the safest management possible. John, having a heart attack means that your heart blood pipes are not getting enough blood supply due to deposition or accumulation of some fatty substance in the heart blood pipes. Because it's not getting blood supply, the sum of the part of your heart muscle is dying every minute that we are waiting. Please don't get scared. Right now you're with me. I'm going to start you with a tablet known as aspirin, which will prevent formation of any further clot. I have already given you a strong painkiller, and if needed, I will give you more. I will check your oxygen saturation. Anytime it goes down to 94 or below, I will start you with oxygen by mask. If you still keep having the chest pain, I will also give you another medication known as nitroglycerin. You can take it by spray or under your tongue. and that helps to relax your coronary or heart blood pipes. These are the immediate management for you at the moment. But this is a rural clinic, John, and we don't have enough capacity to treat you accordingly in here. But because the nearest hospital is 4 hours away, we have to treat you anyway. Right now, I'm going to call the tertiary hospital cardiologist. I'm going to talk about your condition, your ECG finding and everything. And according to the cardiologist, I will go for further management. Because the hospital is 4 hours away, most likely the cardiologist might just advise us to go for the next best approach to treat you, which is administering a medication known as fibrinolytic drugs that is supposed to dissolve any of the clots that's blocking your coronary arteries. I have already asked you some of the contraindications to have those medications, but you are not having any contraindications, so you are safe to have it. But because I'm a GP in here, I'll need to talk with the cardiologist to go for further management. Once you are stable enough, then most likely I will send you through an air ambulance to the tertiary hospital for further management. And also you need to talk about like taking the blood and doing the troponin and all other investigations. Okay, so that's how you discuss. See, the confidence in the voice and everything matters a lot. You can't be like, when you are treating a heart attack patient, your voice should be so confident that patient just can rely on you. Okay, it's very important for a patient to rely on you in such condition. So you have to show that. All good, guys? Any question? All right, who's next? So after Dr. Estella, Dr. Ariba was there. Dr. Ariba, did you do any role play recently with us? Can't remember it. I can't hear you, Dr. Ariba. I can see that you unmute yourself. Yeah, now I can.
Can you hear me now?
Say something. Yeah.
All right.
So you did not do any play with us recently, right?
No, I'm just a beginner.
That's fine. We are looking forward to have some beginners. Okay, I'm going to give you the case. Just give me a minute. Okay, so this is your case. Your 1 minute time is started. All right, so this is your patient. Your patient name is Sarah. You can start.
Hello, Sarah. I'm Dr. Ariba. I'm Dr. Ariba. I can see from the notes that you had loss of consciousness in the morning. How are you feeling now?
Yeah, I'm okay now, doctor. Thank you.
Okay, that's good. Sarah, I would like to ask more about today's episode. Can you tell me in detail what happened?
Yeah, doctor, I was just like started to get up in the morning and went to open my fridge, and then suddenly I just had a fall and I lost consciousness.
All right, Sarah, was it for the first time?
Yeah, that's why I was like really worried that I never ever had it before.
All right, was it sudden or did you feel any lightheadedness or dizziness?
I felt like I know that I was going to fall, and I feel like kind of like lightheadedness or dizziness.
All right, Sarah, can you tell me that did you feel any headache, blurring of vision?
I felt some blurring of vision, but not headache.
All right, any weakness in any part of the body?
No.
All right, blurring of the vision that you tell me, was it like a tunnel-like vision?
You know, it's just like just before I had a fall, I felt like I can't see anything.
All right, Sarah. When you had this episode, did you lose your consciousness completely?
I think so.
All right. Was there any witness?
No, doctor.
All right, Sarah. Can you tell me that did you injure your head during the fall?
No.
All right. When you woke up, when you regained consciousness, were you able to stand up yourself?
Yeah, but I was little confused and dizzy.
All right. And for how long that dizziness continued?
Just a few minutes, and then I was fine.
All right. And did you notice any weakness after that? Weakness of body after that?
No.
All right, Sarah, can you tell me that do you feel lightheadedness or dizziness when you wake up in the morning from the bed, like when you change your posture from a lying to sitting position?
No, doctor.
All right, Sarah, did you have any vomiting or diarrhea recently?
No.
All right, do you feel weak these days?
No.
All right, did you have any fever, rash, or neck stiffness?
No.
All right, Sarah, can you please tell me that do you have any medical condition like increased blood sugar or raised blood pressure?
No, doctor.
All right, Sarah, did you skip any meal?
No, doctor. I don't think so. I just got up in the morning. I was going to have my breakfast. That's all.
All right, Sarah, I'm sorry to ask, but do you smoke or drink alcohol?
I drink alcohol.
All right, can you tell me more about how much alcohol do you take?
It's just like sometimes 5-6 drinks a day.
All right, did you drink last night?
Yes, doctor. I was in a birthday party of my best friend, and we had a lot of binge drinking.
And would you say that did you intake or did you had an increased intake last night?
Yeah, I can't even remember how much.
All right, Sarah, do you suffer from, do you have any family history of cardiac disease?
No.
All right, thank you so much for all the information, Sarah. From your history and from your notes, what I think that most likely you are, this episode of syncope you had was because of your increased intake of alcohol, right? Sometimes this can happen, but it can also happen due to many other reasons, which I thought were least likely in your condition. It can happen due to anemia. It can happen due to any heart disease, or it can also happen due to a nerve in the body that can overstimulate in stressful situations. And it can also happen due to any infection, ongoing infection. It can happen due to conditions like epilepsy or stroke. It can happen due to any polypharmacy, any multitude of medications that we are using. It can also happen due to any excess loss of fluid from the body, like in case of vomiting or diarrhea. In your case, I would like to order a panel of tests, some blood tests like full blood examination, ESR, CRP, blood sugar levels. I would also like to take your alcohol, measure your alcohol levels, and that's it.
Okay, all right. You have got like 2 minute time. That's good. You did really good. Dr. Ariva, you don't like a beginner at all. And that means that you have a very good way of asking questions and explaining things. And I knew a lot of people like that, and you will be some of the people who will rock the exam. Okay, so just keep on doing those, like covering everything that you need for the exam, and you will be fine. Now,
thank you, sir.
Okay, so you did ask like all the questions that's important for a syncope patient, and the way of your asking question was good. The approach was nice. In the history, only thing that I think like was missing, which is your any reproductive. Yes, Dr. Jafar, very good. So any reproductive age patient, especially it's a female patient, 27, we should always ask their period history and about their partner history, any possibility of pregnancy related complications. So that should be asked in here. So just ask that, Sarah, I need to ask you some sensitive questions. So is that all right with you? Yes, doctor. So when was your last menstrual period? Okay, so 2 weeks ago. And how's your period normally? Is it regular or irregular? Then do you get excess bleeding during period? No, doctor. And are you sexually active? Yes, doctor. And you have a stable partner? Yes. Any chance that you have been planning for pregnancy? No, doctor. Okay, so that's some of the questions that you can ask in this particular case. That's the most important, just to rule out, because syncope in the morning can be even just a pregnancy feature. So it could be just a pregnancy. You don't know. So you have to ask all those questions in here. And what else? So you asked severe CNS question, you asked anemia question, postural hypotension questions. I think like nothing else that you could ask. Very, very good that you asked about the alcohol. And also I was so impressed that you asked about the last night drinking. If you would not ask it, I would not give it to you. So this is a very important case for the exam also. Having alcohol
at the last point. I was said from history, nothing is positive so far now. So it has to be something from here.
Yeah, yeah. That's how you get findings in the exam also. If nothing comes positive, you go in deep and deep, and somehow you will end up finding some things. Okay, like there is something why this patient had a syncope. So we have to find that out anyhow. So that's one thing. You could ask one thing, like just to rule out vasovagal syncope, that where you were standing for a long time before you had a fall. Now, it's very unlikely in this case because patient was just opening the fridge. So it's very unlikely, but still we can ask it. Okay. So, and also having a history of sudden cardiac death in the family would be a good idea. Okay. And most likely diagnosis will be, you can say that the loss of consciousness that you had in the morning, it is known as syncope, or it is known as syncope. Now it has a lot of causes, but in your case, I could not find anything abnormal apart from the last night binge drinking that you had. Sometimes when you have a binge drinking, you tend to get hangover effect from the alcohol in the morning. And that's most likely the reason why you had this fall or loss of consciousness in the morning. There is other possibility, like if you have a severe, like if you had a binge drinking, it can even make you dehydrated. And that's why you can have a fall similar like this that you had today. Sometimes it can also lead to salt and minerals deficiency in your body. So that can be one of the other reasons that you had a loss of consciousness. Apart from that, then you go for other differential. So someone who had a binge drinking, these are the most three causes why they have a syncopal attack. Hangover effect, second is severe dehydration, third is salt and like salt and mineral imbalance, like electrolyte imbalance. And necessary investigation, so you like all the basic blood, full blood count, inflammatory marker, liver function, kidney function, especially electrolyte level, blood sugar level. Some of this patient who is intoxicated with alcohol, they can get hypoglycemia also. Okay, so very important to measure blood sugar level. Then one of the other thing I would suggest to do is called blood alcohol level, because this patient was on party last night and had a binge drinking. You can also order for a urine drug and toxic screening. Okay, so these things we can add in this investigation. And if all these things came negative, you can also do a urine pregnancy test. If it suggests, then only you can do a urine dipstick to rule out UTI, and also you can do a ECG later on. So those will be your like second line investigation. All right, so you did really good, Dr. Ariba. Thank you so much. Yes, that's a very good thing. I actually wrote it in my note that one of the other thing, very good, Dr. Amiri. So even though there was no witness during the loss of consciousness, you could ask that any chance that you bite your tongue, or you can say that you wet your pants or had any accident during that time. Okay, that's one thing we can ask. So, like, just like soiled yourself or wet yourself or bite your tongue, that's a good question. We can't ask seizure questions because she did not have anyone as a witness, but these things can be found. So that's a good thing to ask in here. All good? Now, I think like I'll do one role play tonight, another one. And who was next? And Dr. Chaturangi, I'm really sorry. I think like some of other candidates were before you. We might not be able to do it with you tonight, but obviously maybe anytime next. There was someone else who actually say that they will do the role play first. I think Dr. Saeed. And Dr. Shireen, you did role play, I think, in previous class, right? So Dr. Said, you can do role play if you're here.
Yes, doctor, I can do that.
Okay, all good. I'll give you the case. And you will be the last one too. And I'm really sorry, Dr. Chaturangi. I know you want me to do the role. Okay. Now, Dr. Said, we haven't discussed this case in our class. Now, part of the role play session is to find out if we are missing any important case which is important for your exam. So if there is anything that comes up when I'm trying to find out the missing cases, then we try to discuss this in the role play session as well. So that will be your case. try your best according to the knowledge and experience
Okay,
that
doctor.
you have. We will discuss the case later on.
Okay, doctor.
Okay. So this is your case. Your time starts.
Shall we start?
Okay, so we can start. So you will get 7 minutes 30 seconds, and your patient name is Anna. Let's start.
Okay. Good morning, Anna. My name is Sayed Ali. From the notes I come came for the vaccine, but I was checking your blood pressure and your blood pressure came high. And when I was going through your notes, I also found out that you were in the. So I need to ask you a few questions. Is it fine with
Dr. Syed,
Hello?
I'll give a pause. I can't hear you properly. I think like your sound is breaking a lot. So I just gave a pause. What we can do, like, are you using any microphone or anything? You can disconnect if you are.
No, doctor, I'm just using my laptop.
Laptop. Okay. All right.
Yes.
Somehow you're sounding as a blurry or like not understandable sometimes. You can give it a try. That's fine.
Okay.
Okay. All right. So
Uh,
sorry for that.
uh,
And restart.
okay. Good morning, Anna. My name is Sayed Ali. I'm your doctor today. From the notes, I come to know that your blood pressure is high and you were given a medication previously. So I need to ask you a few questions. Is it fine with you?
Yes, doctor.
Okay. So, Anna, came for the vaccination, but the thing is, tell me about when you were medication, this candy sartan.
2 years ago, doctor.
Hello. Okay. And for how long you use this medication? Are you still using this medication?
No, doctor, I stopped it.
How long back you have stopped?
About 6 months ago.
Okay. So you use this medication for 1.5 years.
Yeah.
And what were the signs and symptoms when you were given this medication?
I did not have anything.
What you were
My
having?
doctor just found out that I have a
Mhm.
high blood pressure, and he just started it.
Okay. Were you having any headache, any blurring of vision, any weakness in your body at that time?
No,
Okay. Do you feel anything like headache, any weakness in your body, anything like that at the moment?
no, doctor.
Do you consult your doctor before stopping the medication or you stop abruptly by yourself?
I stopped by myself.
Okay. So how you are feeling after stopping the medication? Do you feel any change, like any headache, any blurring of vision, anything like that? Any weakness in any part of
No,
your body, anything?
no. I feel
Okay. Can you tell
fine.
me
So
more
that's why
about yourself, Anna?
I'm taking the medication.
Okay.
I don't think like
Okay.
I did not think I needed.
Okay. Anna, can you tell me more about yourself? That how is your home situation? Are you living alone or with your family members?
Yes, I'm living with my sister currently. I recently moved to this place.
Okay. Do you have a family history of hypertension as well? Your parents, your siblings have the same problem?
I think my mom had one.
Okay. And how and what you are doing for your living? Are you working somewhere?
Yes, doctor. I'm working in one of the real estate.
Okay. Is it a stressful work?
Yes, I recently got promoted, and it's so stressful, doctor. Sometimes I need to um, go to work in Saturday, Sunday also.
Okay. Along with that, are you taking any recreational medications or any other thing?
No,
Okay. Apart from this candy sartan, are you taking any other medications?
no, doctor. I'm not taking any medication.
Okay. Do you smoke?
No,
Do you take alcohol?
no,
Any allergy you have?
no.
Okay. I need to ask
Read
you a
up.
few personal questions. Is it fine with you regarding your personal and
Yes.
social life? Okay. When was your last menstrual period?
I think 2 weeks ago.
Are your periods irregular?
It's getting irregular.
Okay. Okay. Are you in a stable relationship?
No, doctor. I had a separation recently.
Okay. Are you sexually active?
No,
Okay. When was your last pap smear done?
2, 3 years ago.
Okay. So you know what was the result of that?
I can't remember. I think it was normal, doctor.
Okay. Are you taking any contraceptive pills or any device you have
No,
inside? Any past medical and surgical history? Any surgery done for you before?
no.
Can you tell me more about your diet? Are you taking more of a green leafy vegetables or more of a protein diet?
I try.
Okay. And what about the exercise? Are you doing daily exercise?
I don't have any time for exercise, doctor.
Mm-hmm. Okay. So did you remember when you last checked your blood pressure rather than this 160 which we found here? It's really a bit high today. Did you remember when you checked
No,
your last
doctor.
blood pressure?
No, I haven't, doctor. It's so much trouble to move from one state to another state. So I just did not bother about it.
Okay, thank you, Anna. Anna, I just found out from your history and your notes that you are having high blood pressure. It was a higher limit on both the systolic and the diastolic. Sorry for using the medical jargons, but our heart is usually contracting like a pump, and your blood pressure is coming in both the readings, the high. And I think for the same reason you were advised this pressure medication like 2 years before to get your doctor. And when you came here, we found out that your blood pressure is high. Although you don't have any symptoms, might be because this blood pressure is remaining high for a long time and you are not having any symptoms. But this is a worrisome thing because as you told me that your work is really like a tiring thing and you are getting involved in more of it. So might be this there are this high blood pressure will have an adverse effect on all your organs in the body. So you need to start your medication again. That's the most important thing for you because if the blood pressure will remain high for time, it will affect your eyes, it will affect your brain, it will affect your cardiovascular system, uh, which will lead to adverse complications. Means you will have any time you will have a heart attack, you will have brain hemorrhage, you will have an ischemic stroke, and it will also affect your kidney on the long terms. It will affect your muscles, and it will lead changes in the vessels, which will cause a long time adverse effect for you. Right now, I need to refer you to the ophthalmologist for doing some fundoscopy for you for seeing for the changes in your eyes. I need to refer you to the cardiologist. Sorry.
Doctor, thank you.
Thank you.
All right, Dr. Ali, you did good. Why I say that it's because you did not even know the case, but you tried your best, and you actually got a lot of things which is needed for this station. So good job. Now the important thing in here, let me discuss this case so that you guys and that what's the approach of history and counseling in here. Okay. All right, I'm going to just mute you. So you already muted, that's fine. Okay, so there are cases which is antihypertensive non-compliance case, very, very important for the exam. This is one kind of it, like in which patient is 45 or 40 years, having a high blood pressure, and patient did not come to you to check the blood pressure. She came to you just as part of vaccination, but nurses found out that's a high BP. And then you found that patient was given candesartan or blood pressure medication previously. And that's mostly what you will get. And she recently moved to your place. When you get something like that, there is always a reason why it is given in this stem. And that's because she had a recent separation, or sometimes she just had a promotion in her job and she needed to come to another state for that job. So any of those things can be found in your exam as a history. So the task is history and counsel the patient accordingly. First of all, there are a lot of feedback that's given in the notes. You will find out in the software. And this is another case. Usually I discuss it in psychiatry because there is MMAC in here, but today I will just go through it a little bit, not the full case of this MMAC one. So you're a GP patient who was diagnosed with hypertension 1 year ago, came for follow-up. She is non-compliant on antihypertensive, has been drinking heavily. You did MMAC, found out patient has a short-term memory loss. So that's another question in which you have the same patient where patient is not taking the antihypertensive medication properly. Now, in any of these cases, when you get a patient with a medication non-compliance, any medication non-compliance, the first thing that you need to find out that what's the cause of the non-compliance? Does the patient has any complication for not taking that medication? Initially, I would start with the complication question. So what could be the complication of prolonged hypertension, which is not getting any treatment? So ask about any history of, do you have any chest pain, any shortness of breath, any pain in your leg when you are walking, any trouble with your pee, any swelling of your feet? So all the questions that is important for hypertension, you can ask in here first. I'll go to the approach later on. So that's your first question. The next question you ask is about the hypertension. So when you were diagnosed with high blood pressure, what was the symptoms at that time? Who diagnosed it for you? And I understand that you were started with medication. Okay, do you remember the dose and frequency of the medication? How long you took the medication? Okay, and can I ask, is there any particular reason why you stopped taking it? And how long you are not taking it? The important causes of non-compliance are divided into medicine-related cause, doctor-related cause, and patient's belief cause. So medicine-related cause will be, did you get any side effects from the medication? Do you have any trouble with the cost or understanding the prescription? Then doctor-related cause, that when you were diagnosed and started with the medication, did your doctor discussed in detail about the nature of this condition, the risk and complication of having this condition? Did you also understand from your doctor that what could happen if you don't take this medication regularly? So that's doctor related. Now patient's belief related. do you believe that the medication that given to you, was it helpful for you? Do you think that, or have you been trying any other alternative treatment? Okay, like any natural therapies or anything like that. So those are the questions that you ask first. Once you have done the non-compliance question, then you go for their daily lifestyle. So ask about SNAP and SADMA. So how's your typical daily diet? Do you normally take a healthy, balanced diet? Do you smoke or drink alcohol? How about exercise? Now, one of the important questions is asking about their home situation and work situation. When you find out the home situation, you might find out that the cause of moving to the another state might be the separation. You might need to ask a little bit about their psychosocial history, like at least mood, sleep, appetite, how she is managing it. Or little bit question will be a good idea here to ask. And also the stress at work is very important. Finish with past medical history, family history, and SADMA. Okay, so that's your history in here. 5P, it's not very, very important in here. If you ask, that's fine. Counsel the patient. Now, there is a very good feedback that you guys can follow. Good question. How to approach for personal history without offending the patient? So always says in a way that doesn't sound judgmental. Say that, Sarah, I'm going to ask you about your home situation. I want you to know that whatever I'm going to discuss, that's confidential. Sarah, sometimes in our life, some of the things might not what we expect, but still things might not be just like how we wished for. But that's how it is. You don't need to feel embarrassed about anything. If there is anything that's going on with your home or work life, please feel free to share with me so that I can help you. So anything like just a little bit of good assuring word, that should be enough in here. So in here, like in the initially, when you start conversation in this case, you can start in this way, like, hi Sarah, it's very nice to meet you. From the note, I have found that you are new at this place. How are you feeling here? Are you having a great time? Now, I appreciate you here for coming for vaccination. It suggests that you are a very good patient and you take care of your health. How did the vaccination go? Are you having any allergic reaction, any rash, any pain, any symptoms from the vaccination right now? No, doctor, I'm doing fine. That's really great to know. Now, when the nurse checked your blood pressure today, we found that your blood pressure is a little high. Can I ask a little bit more question regarding that? Yes, doctor. Well, then you go into some of the general health conditions, especially asking about hypertension related complication question. So before I ask about the blood pressure, I would just like to know how is your general health? Any symptoms currently, any chest pain, racing of your heart, difficulty breathing, any problem with your vision, any weakness anywhere? No, doctor. And so we found that you have high blood pressure and previously you used to take a medication for that. Do you remember that medication? Yes, doctor. How long were you on that medication and when you were diagnosed with high blood pressure? And then you go into the detailed question about the non-compliance related question. So ask about doctor related, medication related, and patient related questionnaires. Okay, and lastly, finish with SADMA, lifestyle, home situation, and everything. Nothing much to add. When you come to the counseling, you have to be very, very careful. You can't sound judgmental. And don't scare the patient to death that they're not taking medication and they're going to die right now. Okay? Say in a way so that it sounds like that you're trying to help the patient. So you can say that, Sarah, as as you understand already, that I am worried about your high blood pressure. We call it hypertension, which means that your heart is pumping blood more forcefully and that exerting high pressure on your blood pipes. When you have high blood pressure and that is not well controlled, it can lead to a serious complication. It can lead to heart attack, your kidney, liver, your brain, everything can be involved. You can have trouble with your vision. You can end up having a stroke as well. And that is the reason why you need to take this medication lifelong. Even if your blood pressure is normal, you have to take it. Sometimes you don't even get any symptoms because the high blood pressure usually doesn't cause any symptoms unless you get complication out of it. You will get symptoms when you get a complication like a heart attack or a stroke, but you don't want to have it. Now, you know what condition you have, and if we can treat it properly, we can avoid all this complication in the near future. Because you were not taking that medication for about 5 to 6 months, I need to start checking your risk again. I would like to take some blood, start finding your complications. So I would do full blood count, inflammatory marker, your liver and kidney function, your blood sugar level, and your lipid profile. And also I would like to do a baseline ECG to see if there is any complication that already happened. After that, I would also check your risk of having a heart attack in the next 5 years by using a CVS risk assessment tool. In the meantime, I need you to start the medication that was given to you. Once you start this medication, try to find out if there is any side effect that you are getting out of it. And because your blood pressure is very high, I would start you with a low dose initially and then gradually increase the dose. In the next few weeks' time, I need you to come to me every week, and please make sure you have a blood pressure machine at home and make a diary of checking your blood pressure twice daily, one in the morning, one in the night. And then bring that diary to me next time when you visit me in the next week. I will have a look on your blood pressure and then gradually increase the dose. Sometimes even if one medication does not help, we might need to add another medication to have a good control of your blood pressure. It's not only just the medication who helps, Sarah. You need to have a healthy lifestyle also. I know that going through all of this, having a separation lately, having a lot of work stress, it is not normal. And I'm very sorry that you had to go through this alone. But now you are here. Let me take care of this condition that you are having. And with appropriate intervention, with appropriate support, you will be fine without even thinking about this condition. If you have any trouble with remembering taking the medication, you can use some apps that you can find in the mobile phone these days, and that will remind you of taking your medications daily. I suggest you to start healthy, balanced diet. Try to do exercise even though you are really busy. Now, having a busy life is something which might also increase your blood pressure eventually. So I would advise you to take some kind of leave from your work. At least try to have a balance between your work life and your personal life. Try not to go to your work Saturday and Sunday. Take a leave during the weekend and go to somewhere where you can relax yourself. It is very important for you. Okay. Regarding your separation, if it is affecting your mood and daily life, I would like to do a proper mental health plan for you. And if you want, I can send you to a counselor who you can talk to. So to see that everything that you get from the patient, you need to address those issues. That's the thing. Now, this case is more about management than the history. You have to talk a lot in here. You have to involve your patient every now and then. Okay? And that's how you pass this case. I hope this is clear, guys. So thank you everyone for being here for a long time. Now, as you understand that, I know that most of you who are here, you guys are already enrolled in the course, and we will have a proper orientation class. You already got this schedule, right, in your Facebook group. Now, the course has another Facebook group, so you already should be able to get all the schedule for this month and everything. There is a class tomorrow as well with Dr. Cynthia for random role play. And then on 16th, we will have an orientation class. Now, if any of you who still want to join the class, please make sure that you just send me a message or contact us through the email so that we can enroll you as soon as possible. Okay, the course is designed in a way which there is no other way that you might fail even after doing this course. If you are really working hard and you're doing everything that we are saying, you will have a very good chance to pass the exam in first attempt. Okay, the course is organized in such a way. I hope we have a good time, and also, like those of you who just joined the 2-week session, I hope that you also passed your exam as soon as possible. One of the other thing is very important to know that there is no other alternative rather than giving the clinical exam. Okay, so you have to give your clinical exam for having the general registration. There are some way to avoid it, but that's not very easy. So think in a way that will help you in the near future as well. You have to go for clinical. There is no alternative. Okay, so make sure you pass it as soon as possible so that you don't need to even think about it when you are having a rotation in the hospital or in the GP setting. All right, so just because this is our last 2-week session, I would like to show you the course video for the last time, and then we will be able to finish it tonight. Okay, so this is our course, the 5 months course that's already started. And if you guys have any question, feel free to ask me at the end of the video. All right. So that was all about the course, I guess. So do you guys have any question? All good. So thank you everyone for this free 2-week session. So I hope that you guys enjoyed the class. And from tomorrow, we are going to start our full 5 months course with the course candidates. If you guys have any questions at any time, feel free to ask us. And there is still time for the admission. So just make sure that you email us or send us the inbox. Okay. Thank you. And yes, about the software access, you should be able to get access by the next week time, because now that our 2-week session is done, so everyone, we will start giving you the access right now. So you should be able to get it by the next week. Okay, have a good night then. Thank you all. Bye.